Welcome and thank you for taking the time to learn more about healthcare for people with disability. To assist you in navigating this course, we have included a transcript that you can download and a list of citations and useful websites for additional information. This training is an overview of health advocacy, and we encourage you to use the additional resources to deepen the knowledge on structurally competent healthcare for people with disability. At the end of this recording, we will have a brief reflection and questionnaire for you to submit so that you can obtain credit along with an action plan for yourself. We also have a document with all the citations and resources for each slide available for download. Healthcare students often receive less than 3 hours of education regarding healthcare issues and needs of people with disability. This training has 3 parts. In the first part of the training, we will discuss structural and social determinants of health to understand disparities in healthcare access. By the end of this section, you will be able to describe health advocacy and the importance of multi-level advocacy approaches to understand structural and social determinants of health to access settings-based healthcare. The second part of the training will discuss health and social justice and uprooting structural and systemic bias and ableism. By the end of this section, you will be able to delineate strategies to advocate accessible healthcare to uproot systemic bias and ableism experienced by individuals within healthcare systems. The third part of the training will discuss universal access to health by developing disability cultural humility. You will be able to apply strategies to incorporate accessibility and disability cultural humility across all healthcare practices and services. By rethinking disability, we can consider social justice and health equity for people with disability. Disability does not diminish the rights of people with disability to have self-determination, to live independently with or without supports, to have control and choice over their own lives, and to fully participate in and contribute to their communities through full integration and inclusion. In this preface section, we want to introduce you to disability terminology, the legal and social landscape of disability, and provide foundation on health advocacy and health equity. At the request of Sage Publications, Sarah Troiano wrote the definition of disability pride for the Encyclopedia of Disability, noting that disability is a natural part of human diversity, a celebration of our heritage and culture, and a validation of our experience. Troiano, founder of the first Chicago Disability Pride Parade in 2004, set the goal to promote the belief in society that disability is a natural and beautiful part of human diversity in which people living with disabilities can take pride, a personal and a radical concept. Words matter, and how we address and talk with and about people with disability matters. Most people have been taught to use person-first language. That is where you describe someone as a person first, then specify disabilities such as person with epilepsy, person with diabetes. Person-first language is generally considered to be standard etiquette and a safe guess for many circumstances, including general terms like people with disability. Increasingly, however, disabled people do not want to use this type of language to refer to other aspects of a person. Some people feel that the emphasis of personhood, despite a disability, only contributes to the stigma surrounding disability. Imagine how it would sound to refer to someone as a person with blondness, or a person with tallness, or a person of youth. Although person-first language is a neutral way to discuss a person with disability, it may not always be the best choice. If a person prefers identity-first language, you should respect that preference. Identity-first language puts the descriptor first and is more common among specific disability communities. One such example is the deaf community, where deaf person is generally preferred over person with deafness. This linguistic model positions disability as an identity category, something that is embraced and describes membership within a wider cultural group. Whenever possible, ask how a person chooses to identify rather than assume. Disabled people are the largest and most diverse minority within the population, representing all ages, races, ethnicities, religions, and socioeconomic backgrounds. Yet, disabled people are often not thought of as equals or valued members of society. Disability justice works to move away from segregation, isolation, and ableism and move towards accessibility, equity, connection, and interdependence. People with disability have the same basic legal, civil, and human rights as other people. Civil rights laws have been passed to eliminate discrimination against people based on their disabilities. These laws provide protection, accommodations, and support and enable people with disability to exercise their human rights and have an increased visibility in our communities. Laws have been passed to enable people with disabilities to live in the least restrictive environment and to ensure their medical care, education, employment access, and access to social environments is secured. Starting in 1935, disabled people gained access to medical care under Title V grants to states for maternal and child welfare. In 1973, access to social environments became a reality with the Rehabilitation Act of 1973, Section 504. Children with disability were given the right to education with the Education for All Handicapped Children Act of 75, renamed in 2004 Individuals with Disabilities Education Act, also known as IDEA. The rights of people with disability were expanded with the Americans with Disabilities Act of 1990, also known as ADA, to include access to social environments, public and private, and in 2008, the ADA Amendments Act provided further clarification of the ADA of 1990 to ensure the rights of people with disability. The right to access employment was supported by federal legislation of 2014 with the 7% rule in the Office of Federal Contract Compliance Programs, Section 503 of the Rehab Act of 1973. The 7% rule requires federal contractors and subcontractors to set a nationwide aspirational 7% utilization goal for individuals with disabilities in each job group set up in their existing affirmative action plans for women and minorities. Most recently, President Biden added 2 executive orders to further support to include people with disability across all diversity, equity, and inclusion activities and employment of people with disability by including accessibility. This is the acronym DEIA, Disability, Equity, Inclusion, and Accessibility. So, what is the importance and impact of the Americans with Disabilities Act? It promotes equal treatment. The ADA is a civil rights law that prohibits discrimination against individuals with disabilities in all areas of public life. The legislation promotes social inclusion for people with disability. It ensures they have equal access to public services, education, employment, and other opportunities. It increases accessibility. This law requires public places and transportation to be accessible to individuals with disability. It also raises awareness about the rights and needs of people with disability. It helps to shift public attitudes towards greater acceptance and understanding. It provides employment protections. The law requires employers to provide reasonable accommodations to qualified individuals with disabilities. This helps improve employment opportunities for people with disability. It improves quality of life and health outcomes. It impacts the lives of millions of Americans with disabilities. By providing greater access to health care, the ADA helps improve the overall well-being of people with disability. It promotes equal treatment, increasing accessibility, and improving social inclusion. And lastly, it sets a standard. The ADA has become a model for disability rights laws around the world. It sets a standard for how individuals with disabilities should be treated and accommodated in society. The ADA provides better healthcare access. Healthcare facilities are more accessible, signage has improved, and the healthcare community has become more informed about how to best care for people with disabilities. However, when it comes to knowing the ADA, we need to do a better job educating healthcare workforce in understanding the disability law. As reported in 2023 ADA survey of 714 U.S. physicians in outpatient practices, 71% did not know who determines accommodations, 68% felt at risk for ADA lawsuits, 36% reported little or no knowledge about their legal responsibilities, and 21% could not identify who pays for needed accommodations. When it comes to framing of the Americans with Disabilities Act, the word disability is a legal term rather than a medical one. Therefore, the ADA's definition is different than how disability is defined under other laws, making a significant shift in how we view disabled people. The ADA defines person with disability as a person who has a physical or mental impairment that substantially limits one or more major life activities. This also includes a person who has a record of such impairment or who is regarded as having a disability but does not currently have a disability. A person is also covered if they are perceived by others as having such an impairment. Only one of the three descriptions must be true for a person with disability to be protected from discrimination by the ADA. The ADA shifts our view of disability from a medical model to a social model. By shifting from a medicalized view to a social model view, we validate the prejudiced attitudes, discriminatory behavior, and institutional and legal constraints experienced by other disadvantaged and excluded groups. With the social model, people with disability understand their shared stigma, experiences, and social status with their peers with disability. Many of these stigmatized experiences and characteristics are similar to other groups commonly recognized as minorities, including racial and ethnic minorities. In the image, we can see how the medical model of disability views disabled people as sick, defective, with internal problems that needed to be cured in order to be happy and function in their lives. The social model of disability developed by disability rights activists in the 1970s and 1980s says that individual limitations are not the cause of disability. If societies were constructed in a way that was accessible for people with disability, they would not be restricted from full participation in the world around them. Within the image, the challenge for disabled people is the external barriers, such as technological, communication, human rights violations, disabling physical environments and organizations, and most importantly, attitudinal biases. According to the World Health Organization, people with disability are the largest minority with 16% of global population. More people are living with disabilities, particularly in developed countries, due to medical advances supporting more people with disability. Disabilities are often associated with visual manifestations like canes, wheelchairs, and sign language. So we tend to think of disabled persons as someone who is paraplegic, quadriplegic, blind, or deaf. However, most disabilities are in fact non-apparent, such as diabetes, arthritis, chronic heart problems, HIV/AIDS, and multiple chemical sensitivities. It is estimated that 70 to 80% of disabilities are non-apparent. Over our lifetime, most of us will become a temporary or permanent member of disability community. Creating inclusive, accessible futures is important for all of us. Better care for the great diversity of people with all types of disabilities, and by extension all people, requires better engagement with and reflection upon the rich and complex meaning of disability. In the world of disability services and supports, names and naming matters. What we name and call a condition has consequences for how people perceive themselves and others. It is important to note that the terms disability, disease, and illness are not interchangeable. Disease is a harmful condition affecting the body with symptoms, signs, and anatomical changes. Disability, on the other hand, is any condition of the body or mind that may make it difficult for a person with disability to do certain activities or live, learn, work, play, and love in their community. Disability can be a part of a person's identity, and not just in negative ways driven by challenges in ableism. And it's never too late for a person with disability to rethink their approach in relationship to it. Disability is diverse, complex, contextual. It intersects with all parts of human identity, including race, ethnicity, sexuality, gender, age, and culture. It develops new abilities and expectations. It innovates new ways of living for everyone. However, there is no diversity, equity, and inclusion without disability accessibility. Health advocacy aims to bridge the gaps within our healthcare systems to ensure that people can access affordable, acceptable, effective, and high-quality healthcare. Health advocacy activities can ensure access to healthcare, navigate healthcare system, mobilize resources, address health inequities, influence health policy, and ultimately create system change. Advocacy efforts must include the full and direct participation of people with disability who are most impacted by advocacy efforts. Hence, nothing about us without us. While the terms equity and equality may sound similar, the implementation of one versus the other can lead to dramatically different outcomes for marginalized people. The word equality is defined as the state or quality of being equal, corresponding to quantity, degree, value, rank, or ability. Equality is usually straightforward. 4 identical bicycles in the picture above, given to 4 people, is a state of equality. Everyone has exactly the same bicycle. The word equity is defined as the quality of being fair or impartial. Fairness, impartiality, or something that is fair and just. Equity is more complicated than equality. If you're trying to achieve equity, you're trying to do something in a way that is fair or impartial. In modern times, the usage of the word equity has increased due to concerns about social and racial justice and a desire for fairness for marginalized communities and historically oppressed groups. In terms of the law, minority groups, including people with disabilities, often have technically equal rights, but are still treated unfairly due to unequal access to resources or opposition from dominant groups who deny others equal representation while still acting within the law. And how to achieve equity for people with disability? Addressing social determinants of health is a primary approach to achieving health equity for people with disability. The image of 2 fish in 2 fish bowls underscores the importance of structural and social determinants of health. Would fish 1 on the left be happy, safe, and healthy if its water were dirty? What if its bowl were cracked and the water was leaking? No matter how fish 2 on the right tries, it may never reach its full health potential due to its dirty water and cracked bowl. Remember, environment affects health more than individual behaviors. Structural social determinants of health are conditions such as physical and social environments which contribute to health outcomes. These conditions include economic and social policies and systems, development agendas, social norms, discrimination, climate shifts, and political systems. Health disparities are the avoidable differences that result from cumulative social disadvantage. Many factors contribute to health disparities, including access to care, poor quality of care, community features, environmental conditions, language barriers, health behaviors, and genetics. While 80 to 90% of persons' well-being is driven by the social determinants of health they face on a daily basis, the price of medical care, which only directly influences 10 to 20% of health outcomes, is the single biggest factor behind U.S. healthcare costs, accounting for 90% of spending. Addressing health issues and the factors outside of the health system that lead to poorer outcomes is a crucial part of solving healthcare. People with disabilities face more health inequities than their non-disabled peers, including disparities in social determinants of health. They're less empowered and have lower socioeconomic status, tend to live and work in more degraded environments, and have a higher exposure to risk factors for disease, as well as physiologic impacts from chronic stress leading to worse health and shorter lives. Many people with disability struggle to obtain proper access to quality healthcare services because of financial, cultural, and structural barriers, struggle to receive higher education, face housing discrimination, substandard housing, and high rates of homelessness, and have higher violent crime victimization rates by age than people without disabilities across all racial groups. Daphne Frias, youth activist, organizer, storyteller, and peace builder, states that disabled people live at the intersection of all systems of oppression and social justice issues. There isn't one issue or one intersection where you will not find disabled individuals advocating for or experiencing the effects of those issues. The Health and Human Services Advisory Committee on Minority Health describes a person from a racial or ethnic minority group who also has a disability as facing a double burden from the additional health and social challenges. The Centers for Disease Control and Prevention website has excellent infographics related to how disability impacts all of us. This image reports the disparities in health behaviors and chronic conditions between disabled adults and their peers without disability. Adults with disabilities are more likely to have obesity, smoke, have heart disease, and have diabetes compared to their non-disabled peers. Comorbidities are the presence of two or more diseases or medical conditions at the same time in a patient. People with disability often have complex health histories requiring more healthcare provider time during healthcare visits. Diagnostic overshadowing is another issue for disabled people, where healthcare providers often have a tendency to attribute all other health problems to person's disability, thereby leaving other coexisting conditions undiagnosed. Because of diagnostic overshadowing, people with disability may experience poorly managed multiple chronic conditions. These undetected health issues, lack of screening and prevention for vision, oral health, hearing, mental health, fitness, cancer, are contributing factors to poor health outcomes. Furthermore, healthcare professionals may view disabled patients as having lower quality of life or being unwell as a result of their disability. One of the reasons why healthcare professionals may have this view is that most providers are able-bodied or do not identify their disability, which misinterpret quality of life and put people with disability at risk for poor health outcomes. The graphic on the left side of the slide depicts the impact of poor access to healthcare providers and lack of disability cultural humility in the healthcare. For disabled people, 1 in 4 do not have access to a usual healthcare provider, 1 in 5 have unmet healthcare need because of cost in the past year, and 1 in 4 did not have a routine checkup in the past year. Access matters. The barriers in accessing healthcare are structural and attitudinal. Disabled people face barriers in accessing healthcare due to assistive equipment that they used. For example, a person who uses a wheelchair may not be able to be weighed on office scale or needs an exam table with adjustable heights. Communication accommodations for patients with hearing, vision, or speech disability present different challenges. One doctor hired a sign language interpreter for a deaf patient. The interpreter's fee was so high that the doctor lost $30 every time the patient came to see them. Patients with disabilities often have complex health histories, and doctors have a shrinking amount of time to spend with each patient. The healthcare bias and reluctance to care for disabled people noted within the 2022 seminal article, "I'm Not the Doctor for You," perpetuates healthcare disparities experienced by many disabled people. Physicians' bias and reluctance in caring for disabled people is often connected with feeling overwhelmed with providing care, knowing people's rights within the Americans with Disabilities Act, and being inadequately reimbursed for accommodations. Physicians reported that they developed techniques to discourage patients with disabilities from trying to make appointments, such as telling patients that their practice does not accept new patients, canceling appointments after discovering a patient is disabled, explaining that their office is too small for their wheelchair, or the machinery isn't good enough for you, or saying outright, maybe you should go somewhere else, or attempting to discharge disabled people from their practices. In another study, it was found that 84% of healthcare professionals implicitly preferred people without disability. Repeated exposure to socioeconomic adversity, political marginalization, racism and ableism, and perpetual discrimination can harm health. This harmful effect is called weathering. Disabled people may experience the effect of weathering, which is magnified among women with multiple underserved identities and disabilities, especially people with intellectual and developmental disability. Challenges with healthcare access and care for people with disability compared to non-disabled people consist of more mental distress, which is also greater among people experiencing poverty, unemployment, and unmet healthcare needs due to cost, and more intimate partner violence among women, and abuse and violence from people who provided direct care services. In considering ways to reduce health disparities of people with disability, we should think about upstream downstream approaches. We want to highlight the importance of health promotion and the influence of social, economic, environmental, and cultural factors on health equity, which we discussed previously. In order to illustrate this point, consider a parable. Two friends were fishing on the riverbank when they saw a person struggling in the current. They rescued them. Soon they saw another person struggling. They rescued him too. This continued all afternoon. Finally, the exhausted fishermen decided to go upstream to find out where and why so many people were falling in. They discovered a beautiful overlook along the river's edge without any warning signs or protective barriers. The fishermen went to community leaders to report the number of victims they had rescued and explain the connection to the unprotected overlook. Community leaders agreed to install a protective guard and post warning signs. Preventing the problem saves resources, energy, and lives. This parable shifts focus from downstream individual treatment to upstream prevention strategies for the whole community with a focus on the vulnerable. Healthcare providers are typically so caught up in constantly rescuing victims from this river that they have no time to look upstream to see what is pushing their patients into the water. As a result, they should refocus and look upstream, where the real problems mostly lie, and learn about broad lessons for how to intervene from that vantage. In the next few slides, we want to give you some resources on how to look upstream. The Everyone Project from the American Academy of Family Practitioners provides simple education and resource tools to help you advocate for health equity. They include screening tools, a neighborhood navigator, and an action plan to discuss midstream and upstream teachable moments to access needed resources. There are many ways that healthcare providers can take action and address health and social challenges at the individual, practice, and community levels. On individual level, opening health conversations by asking patients about social and health concerns in a sensitive and caring way, brainstorming options together, referring patients and helping them access benefits and support services. The American Academy of Family Physicians Social Needs Screening Tool can help healthcare providers screen their patients with disability for social determinants of health, identify community-based resources to help them, and work with patients to develop an action plan. The tool screens for 5 core health-related social needs, which include housing, food, transportation, utilities, and personal safety, as well as additional needs of employment, education, childcare, and financial strain. In education, standardized patients play a large role in helping students build competency and better support patients with disabilities. Interprofessional Education Standardized Patient Simulation Project at the University of Illinois Chicago is a collaboration between the Colleges of Nursing, Dentistry, and Pharmacy, the Cooperative Career Experience Certificate Program, UIC School of Theater and Music, and Chicago Disability Artists and Theater Community. It features actors with various intersecting identities such as racial and ethnic minorities, intellectual disability, non-apparent disability, physical disability, and sensory disability, with the goal to teach the students about the lived experiences of persons with disability and to develop students' understanding of disability-related issues. Healthcare providers can take action in their practice to reduce feeling overwhelmed, overworked, and lacking time when patients have complex, intertwined health and social challenges. Patient navigation helps people get the healthcare and other resources they need to be as healthy as possible. Patient navigators work with people, their families, and their caregivers to overcome barriers in healthcare. At the community level, healthcare providers can partner with local organizations and public health and local leadership, get involved in needs assessment and health planning, and advocate for more supportive environments for health. They can also provide a mapping of benefits and local referral resources. To map to local resources, the American Academy of Family Physicians has developed Neighborhood Navigator. This interactive tool can be used at the point of care to connect patients with supportive resources in their neighborhoods. It lists more than 40,000 social services by zip code, including services for food, housing, transportation, employment and legal aid, and financial. Additional resource is a social needs patient action plan, a quick form to guide a discussion with patients about their social determinants of health and document a plan to address them. The form is available in 7 languages. The action plan can help guide healthcare providers to have teachable moments with their patients, addressing those midstream and upstream interventions. Social justice in healthcare equals delivering high-quality care to all individuals. People with disability deserve a right to good health. Still, there are inequities in health that are unjust and can be avoided. COVID-19 pandemic exposed the vulnerability of disabled people in the U.S. healthcare system. For example, Matthew Foster, pictured on the right, worried about being in the back of the line for a ventilator if he contracted severe COVID-19 because he has Down syndrome. At that time, half of states in the U.S. had policies with the type of provisions that advocates say discriminated against people with disabilities. Unfortunately, even with the protections of the Americans with Disabilities Act, our society has been structured to often systematically oppress, discriminate against, stigmatize, and in circumstances like COVID-19 pandemic, deny care to those who are not able-bodied. This is called ableism. Like racism and sexism, ableism classifies entire groups of people as less than, and includes harmful stereotypes, misconceptions, and generalizations about people with disability. It is the discrimination of and social prejudice against people with disability based on the belief that typical abilities are superior. In healthcare, ableism intersects across multiple identities, including race, gender, ethnicity, and sexual orientation. Oftentimes, discrimination experienced by people with disability is often seen as a social etiquette issue versus a social justice or equity issue. While healthcare providers consciously have good intentions and positive attitudes towards people with disability, research documents pervasive, implicitly negative attitudes. Ableism appears in many ways and exists in different levels of society. It includes institutional ableism, where disability is a problem that needs fixing. It is often pervasive in teaching and health policy. It affects the entire healthcare system and the well-being of patients. Interpersonal ableism takes place in social interactions and relationships. For example, a parent of a child with disability might try to cure the disability rather than accept it. Internalized ableism is where an individual consciously or unconsciously believes in the harmful messages they hear about disability and applies them to themselves. For example, a person may feel that disability accommodations are a privilege, not a right. On a societal level, ableism can be seen as the lack of compliance with disability rights laws like the ADA, segregating students with disabilities into separate schools, failing to incorporate accessibility into building design plans, buildings without braille or on signs, elevator buttons, etc., building inaccessible websites, the assumption that people with disabilities want or need to be fixed, using disability as a punchline or mocking people with disabilities, and refusing to provide reasonable accommodations. Everyday or minor ableism exhibited through choosing an inaccessible venue for a meeting or event, therefore excluding some participants. For example, not using a microphone to speak to the group for access. Questioning if someone is actually disabled or how much they are disabled. Assuming people have to have a visible disability to actually be disabled. Wearing scented products in a scent-free environment. Framing disability as either tragic or inspirational in news, stories, movies, and other popular forms of media. Talking to a person with disability like they're a child, talking about them instead or directly to them or speaking for them. Making a movie that doesn't have audio description or closed captioning. Using someone else's mobility device as a hand or footrest. Or asking, how did you become disabled? Microaggression, a term used for ordinary verbal, nonverbal, or environmental slights, whether intentional or unintentional, communicates hostile, derogatory, or negative attitudes towards marginalized groups. Again, words matter. Ableism is ingrained in every aspect of our daily living and in the language we use. It can be hard to learn that some of the things we think or say are oppression of persons with disabilities. Many of us, including people with disabilities, still have ableist views and use ableist language without realizing it. This is because many of us learn from disability mostly from non-disabled parents, doctors, therapists, and teachers. Some steps in unlearning ableism include acknowledge your own ableism. It is important to recognize that collectively we have learned ableism from being a part of society. Disability is just another way for a mind and/or body to be. Disabilities vary. Some are non-apparent. Stop looking for fakers. Listen to and learn from persons with disabilities. But remember that people with disability are not here to educate you at your whim. Take responsibility for your own learning and do your own research. Follow disability activists on social media. Hire people with disabilities. Push for greater accessibility. Avoid ableist labels and expressions. And keep in mind that no disabled person can speak for all. A path towards achieving access to universal health care for all starts with developing disability cultural humility. Since the 1990s, a growing field of disability studies is increasingly examining social and institutional factors such as organizational policy, legislation, socioeconomic influences, dominant discussions, and attitudinal context on health and healthcare for disabled people. This information is providing the necessary context to incorporate disability as a structural and social determinant of health and a source of inequity. Additionally, we're able to use this information to redesign healthcare systems and practices with an understanding of disability as being at least partially socioculturally constructed, where people are disabled predominantly or in part by social structures that limit access, not by bodies or minds. As we increasingly appreciate the social structures that limit access for disabled people, rather than their bodies or minds, we can more easily see how societal attitudes and norms prevent people with disability from being able to live, learn, work, play, and love as they choose. Healthcare professionals have an enormous role in supporting people with disability to develop identities that value their perspectives as disabled children and adults. To include disability cultural humility in healthcare practice, we need to shake our collective selves free of that convenient illusion that we are off the hook because we know ourselves to be kind, compassionate, and professional in all of our patient interactions, regardless of race, disability, or privilege. That is simply no longer enough. Rather, we need to understand that simply by living our daily lives within a system that affords us unearned privilege, we are complicit in benefiting from it. We who are free from the daily fear of encountering hateful attitudes or more subtle microaggressions from the persons, institutions, and systems, those around us, have a special obligation to be allies with those who are not. So, how does being a disability ally look like? First, educate yourself. Learn to actively listen. Expand your knowledge and awareness of disability issues by taking courses or reading books and articles. Identify common microaggressions and eliminate them from your words and actions. Examine dynamics of power and privilege and ways societal structures include and exclude groups of people. Next, practice accountability. Lean into discomfort and consider new perspectives. Avoid retreating into privilege when you're tired, overwhelmed, or don't want to engage. Remember that those with less privilege don't have that option. Be a role model. Model inclusive language. Resist stereotypes and acknowledge oppressive histories within and outside of your communities. Raise awareness around social issues related to people with disability. Examine media bias. Encourage your clubs, classes, and workplaces to use inclusive practices and policies. Support other identities and communities. Listen first or ask how you can support and help, and then work in solidarity with that community. Take action. Create collaborative events with other student organizations that are inclusive of people with disability. Vote and lobby for disability rights. And words matter. We have a responsibility to recognize the authority of people with disabilities as experts about their own lives, health, and communities, and to elevate their voices. For example, people who use wheelchairs for mobility may not want to be represented as being in a wheelchair, wheelchair-bound, or confined to a wheelchair, as represented in the image on the slide. Instead, their chairs are a mode of transportation and provide freedom and accessibility to engage in their communities. Having providers who share their disability identity and have a strong sense of disability advocacy and pride can decrease the risk people with disability experience in healthcare. Increasing representation of people with disability in healthcare education programs and healthcare systems is one way of ensuring diverse workforce. Disabled role models, including disabled healthcare professionals, can model advocacy skills, teach about disability legal and civil rights, demonstrate and value their disability as a source of pride. Health professionals with disability have a wealth of knowledge about and experience in achieving goals through accommodations that could benefit patients with disability and diversify health professions. While we're still working on attitudinal access, physical and environmental access has been much easier to achieve through universal design strategies. To design accessible spaces for all, use of universal design can support access to physical and environmental spaces. Universal design accommodates people with disabilities, older people, children, and others who are not average in a way that is not stigmatizing and benefits all users. It results in easier use for everyone, and it reduces the need for design modifications later when abilities or circumstances change. After all, labels that can be read by someone with low vision are easier for everyone to read, and building entrances without stairs assist equally someone who moves furniture, pushes a baby stroller, or uses a wheelchair. Consider the questions. How usable are your healthcare services and facilities to people with disability? Can people access the front desk with trained staff? Can people move freely throughout your facility, including getting through the doors and into the bathroom? Can people be weighed who cannot stand on the scale? Do people need support in obtaining and filling out paperwork? Communication is one of the most significant barriers reported by healthcare professionals providing care for people with disabilities. On this slide, we see the quotes from young adults with intellectual and developmental disability in response to a question about what did they want from their healthcare provider as they transitioned into adulthood. I wish my healthcare provider would have provided resources about medical supply companies, peer support, learning about identity, culture, and disability pride, vocational rehabilitation, peer mentoring opportunities, negotiating referrals to other providers, assistive technology, home modification and in-home support, accessing health insurance and negotiating employment and Social Security benefits, strategies to find disability-friendly providers. Treat people with disability as you would people without disability. To open communication, start with, "Hello, how are you? How can I help you today?" Communication is essential to how we support people with disability within healthcare services. When making an appointment, questions such as, "How can we arrange your appointment to best meet your needs? What are your communication needs? Is assistance wanted?" can help ensure that people with disability receive the care they need and deserve, while increasing overall patient satisfaction and improving operational efficiency. During an appointment, feel free to offer assistance to a person with disability or ask how you should act or communicate, but do not automatically assume that the person needs assistance. Wait until the offer is accepted. Look directly at an individual with disability, addressing them even if a companion or sign language interpreter is present. Avoiding eye contact sometimes increases tension. Persons with hearing impairments may rely on speech reading and may need to look directly at your face. Adults with disabilities should always be treated as adults. Do not assume that a person with disability is more fragile or sensitive than others. These feelings may make you reluctant to ask certain questions that should be asked. When meeting a person with a visual disability, always identify yourself and anyone else who may be with you. When conversing with a wheelchair user or a person of short stature, try to be seated to facilitate eye contact. Treat people as people and do not assume that a person with disability is more fragile or incapable. There are numerous strategies to navigate communication styles. If you do not understand, say so, do not ignore. Minimize background sounds, ensure a well-lit area, and keep hands and objects away from your mouth. If someone uses a communication device, ensure access to device. Ask how much time is needed, and ask questions with short answers or nonverbal confirmation. In telehealth services, accessible design, including digital features that adjust visual elements such as color and contrast, are key to increasing accessibility. Features such as screen sharing, interactive visual activities, compatibility with screen readers, and live texting chat capability during calls are all helpful features that improve patient accessibility. Communication is the basis of all layers within the healthcare system. While it is often challenging for patients and providers and can make a life or death difference, understanding evidence-based strategies for effective communication in healthcare is critical. Patients need to feel safe to communicate honestly and openly with their healthcare providers to receive effective treatment. Providers need to convey treatment plans and health education clearly, accessibly, and compassionately so that patients can receive optimal care. Administrators and providers need to share information ethically and responsibly to protect patient confidentiality. And healthcare organizations need to apply culturally responsive measures to bridge communication gaps between stakeholders. Many people, even people with high literacy levels, struggle to understand health information. This has significant impact on health outcomes. Nearly 9 out of 10 adults struggle with health literacy. For people with disability, health literacy may be more challenging due to lack of accessible health education or health education inclusive of their disability. Advocating for health literacy is critical for accessing equitable health care and improving health outcomes. High health literacy skills can improve health status, increase correct use of medication, increase knowledge of health, disease, and treatment management, and healthcare perceptions and experiences. As we approach conclusion of this training, we want you to leave with the message that disability is a natural and beautiful part of human diversity. Today, human diversity encompasses disability visibility, where disabled artists are transforming the less than human view of disabled people. We're starting to question ableist tropes and ask, What perceptions do healthcare students have when they see medical images of children with disabilities in journals or as teaching tools? And how do these perceptions change when people with disability are represented in mainstream media, on stage, or film? As a personal and radical concept, authentic representation can actually shift societal cultural values. It is the key ingredient in empowering disabled people to remove societal barriers and change their social determinants of health. Opening doors for people with disability to access equitable healthcare provides a rich opportunity to embrace the unique culture, language, resilience, and diversity among the disability community. By asking, can people with disability access equitable healthcare to improve their health, we can collaboratively work to address the barriers in healthcare and ways that they can be eliminated. We can implement accessible healthcare practices and improve quality of healthcare for everyone. Justina Miles, a nursing student at Bowie State University, pictured on the right, is the first female deaf performer who did an American Sign Language interpretation for the 2023 Super Bowl halftime show. Ms. Miles' American Sign Language performance transforms how we value healthcare professionals with many types of disability to inform new practices in healthcare. Thank you for your participation in the health advocacy training. We wanted to leave you with a quote that only through a process of transformative education leading to systemic change can healthcare be rehabilitated into a safe space for people with disabilities. We hope that you found this training to be a valuable learning experience for your interprofessional education and future interprofessional collaboration. Please complete your reflection questionnaire, and we appreciate your valuable insights and feedback and contributions. Thank you again.